Let's talk about something that sits in almost every bathroom cabinet in the world, and that is petroleum jelly, aka Vaseline. I know we have a lot of patients that use it or try to swear by it, but when it comes to diabetic feet, I just tell them a no when it comes to that because I think it sometimes quietly works against the healing process, especially when things are already wrong. Because, in diabetic foot care, when it comes there's a fine line between moisturizing and maceration, especially when there's a wound present, and that line is thinner, way thinner, like a veil, thinner than people assume it to be. So we're gonna break down what Vaseline actually does, how it helps, how it harms, and what lotions are safe and more effective for our diabetic patients and our post-wound healing patients. So what Vaseline really is. Vaseline is petroleum jelly. It's not a moisturizer in a traditional sense. The job, the one main job of Vaseline, it creates an occlusive barrier, meaning that it seals moisture in and it keeps air and water out. It does not hydrate, okay? Let me just say that again. It does not hydrate. It prevents water loss, aka prevents transepidermal water loss. It softens dry skin over time by trapping in moisture. It protects against friction. So pretty much think of Vaseline like plastic wrap over your skin, okay? So who invented Vaseline? So the story begins with Robert Cheeseborough. I hope I'm pronouncing his name right. Cheeseborough. Let me just spell it out. Chesebrough, a young chemist in the 1850s while visiting oil fields in Pennsylvania, Cheeseborough. Oh, so he's like named after a part of Pennsylvania. Oh no, while visiting oil fields in Cheeseborough, okay, forgive me. Cheeseborough, and I really hope I'm pronouncing his name right. He noticed that workers were collecting a waxy residue called rod wax from drilling equipment. And the workers claimed something fascinating. They were applying the material to cuts and burns and cracked skin. Whether it healed the wounds or simply protected them was very unclear, but the young chemist was actually intrigued. And he spent years refining the substance until it became this purified, semi-solid mixture of hydrocarbons. And in 1872, he patented the product and named it Vaseline. Where did he get that name from? They suspect, okay, they believe that he used the word Wasser, Wasser, which is German for water, and Elon means Elaion, Greek for oil, okay? And together he thinks it's water and oil. So why did Vaseline become so popular? Vaseline solved a major problem. The skin loses moisture continuously through a process called transepidermal water loss. And when the skin dries, of course, it cracks, right? Cracks are formed. The crack forming creates the split in the skin, right? And there's a barrier that the bacteria can enter right now, and then bacteria enters, inflammation increases, and healing slows down. But when they notice, they put petroleum jelly, okay, creates this waterproof barrier, and studies have shown that petroleum jelly dramatically reduces water loss from the skin surface, and that's how it became this effective occlusive moisturizer that's developed, okay? I do not recommend Vaseline on patients, but I always like people to understand the origin and what exactly it's doing. Don't just say no, make them understand why you're saying no, do not use this on your skin, okay? So what happens when you put Vaseline on your skin? Think of skin as a brick wall, and the skin cells are bricks. The natural oils are the mortars, and when diabetes damages the skin, right, the bricks loosen, the mortar disappears and the cracks develop because a lot of diabetics have dry skin. And so that's the problem that we encounter. We have patients, I'm like, what were you putting on it? They were like, I was putting Vaseline on it. I'm like, no, don't do that. Because Vaseline acts as a temporary sealant. So it reduces water loss, it softens the calluses, right? It protects against friction, it improves skin flexibility, it helps craft heals over time, correct? But, you know, it still remains a component. of many modern day skin protectants. Okay. So why does this matter in diabetic feet? Because we have patients who are diabetics and non-diabetic constantly putting Vaseline on their feet. It doesn't really help, especially if there's a problem. Like I have patients doing that when they have athlete's foot, and I'm like, no, you're kind of making it worse because it's retaining the moisture, it's making the fungus even worse, it's causing maceration, things like that. Okay. So never, I always tell patients never self-medicate. Okay. So diabetic skin is already dealing with something like they have the autonomic neuropathy, and that causes reduced sweat production, which causes, or in result, it does cause excessively dry skin, right? And the poor circulation and the slow cell turnover and the high increase of fissures, the fissuring and the cracking, and reduced immune response. So the dry skin in a diabetic foot is not just cosmetic; it's a structural risk because it causes these cracks and fissuring. And the cracks in the skin, what is that? That is a portal of entry for the bacteria, and that is an increase of potential ulceration, right? So yes, moisture balance matters, but not with Vaseline. We're not using Vaseline. So when does Vaseline help? Vaseline helps. The good uses for Vaseline is with intact skin, okay? Intact dry skin, no open wounds. Sometimes they use it around heel wound edges, okay? I would just let my wound care specialist deal with that. Cracked heels, no, with no fissuring, okay? And then sometimes they use it as nighttime barrier. I don't recommend it. I just like my patients to use the actual diabetic lotion or amylactin. Do not put it in between your toes. I'm going to say it again. Do not put it in between your toes. Do not put it in between your toes. They like to put it on and apply it on slightly damp skin, a thin layer. But honestly, I think Vaseline works really well on the face, okay? A lot of women swear by it, older generations swear by it when it comes to the face and helping your face keep that moisture in and slows down aging, right? But I don't recommend Vaseline for diabetic patients, okay? I just don't. But this is where things get clinically important. You do not use Vaseline. Do not. And I'm gonna, if I could shout, I would. But do not use Vaseline on open diabetic ulcers. We've had patients like that. They have done that because they've seen it at heals, like little cracks or burns, things like that, right? Do not use it on diabetic ulcers. Do not use it on anything that is actively draining. Do not use it on interdigital spaces, like I said, in between your toes. Do not use it on anywhere there is a suspected infection. Do not use it on macerated skin. Why? Because Vaseline blocks your oxygen exchange. Remember, we already have a little bit of oxygen deprivation going on in a diabetic skin, right? On a diabetic ulcer. Vaseline blocks oxygen exchange. It traps moisture in it, but it also traps bacteria in. It can worsen maceration. We do not want maceration at all. Okay. We do not. We want moisture balance. Do not want maceration. It can disguise a worsening infection. It can create a beautiful, perfect anaerobic environment for those deep, nasty wounds. So, in the end, do not use it. Okay. So, in wound care, it can turn a healing environment into this sealed infection chamber if it's misused. So, what type of lotions actually work for our diabetic patients? Let's like upgrade this. So, a good diabetic foot lotion should include a hydrant, so something that has a little bit of water content, repair barrier function, non-irritating because their skin is sensitive, be fragrance free, and support a ceramide restoration if possible. So one of the gold standards in diabetic lotions are like urea cream, right? Urea based cream. And you have to go by what your physician recommends, okay? Don't just do it on your own and find one that's online. I know we go with reviews, but I just go with what the experts say. I would go with what the physician says because every foot is different. They know what you're more prone to, but urea-based creams are very helpful, 10 to 25%, right? It works because urea breaks down those thick skins. We use them also for the patients who have a lot of calluses, right? Like amylactin, right? What else? Breaks down the thick skin, the hyperkeratotic skin, pulls moisture into the stratum corneum, and it softens those callus-prone areas. That's what we want, right? Because our calluses for our diabetic patients, or even on any patient that has a callus for a very long time, the skin breakdown underneath the callus happens, and that turns into an ulcer. So urea-based creams are really good for cracked heels, callus feet, early fissuring prevention. Now, a ceramide-based moisturizers, these help rebuild the skin barriers. They're ideal for chronic dryness, aging skin, and the post-healing skin. They support the brick mortar structure of the skin. Now, there are glycerin-based lotions. These are humectants, meaning that they pull water into the skin. They're light, non-greasy feel. They're safe for daily use, best for maintenance care or mild dryness. Now, we do have some petroleum plus barrier creams. These are under controlled use, right? Things like zinc oxide or dimethicone. Okay, these are best for skin protectants for friction, peri-wound protections. I like using some zinc oxide, especially on some venous ulcers. Yeah, because it helps protect the skin barrier along the skin that's already healed, right, from breaking open more, right? And also a nice drying agent will help keep the skin nice and dry because, you know, venous ulcers are these wet wounds, but the big clinical rule is that separates general skincare from diabetic foot care prevention. Moisture, intact skin, protect, but do not seal any active wounds, any crack or active wounds. Okay, that one sentence can prevent many complications. Just follow what your doctor says. Okay, and most important rule is do not put it in between your toes. We have a lot of patients. There's a lot of patients that actually end up with a toe amputation because they had a very macerated maceration in between their toes, and then the skin breaks down so much in between their toes, so badly because also they don't feel it that bad until it gets worse, where they have something called dactylitis. They have this 3 times swelling inflammation of at least one toe, right? Because the infection already went down to the bone. They don't feel it because of the neuropathy, okay? So you gotta look in between your toes. That is a very important component of your daily diabetic foot inspection care, checking in between your toes. If you notice some whiteness or maceration, we go to the doctor immediately, figure out if they have to figure out if it's a fungus or if it's just dry, too wet in between it, and we'll dry it out, okay? I like to tell my patients who have fungus in between their toes, you can use some iodine, you can use some ultraviolet. It depends on what I prescribe because, I get afraid sometimes with patients when I give them the ultraviolet because one time the patient put it on their toes and yeah, that's not what it was for. And the toes were stained for a while, but alcohol takes it off, like rubbing alcohol. But yeah, no, I just put on the ginger violet for the patient because it's still staining and yeah, and they could be doing it until the next follow-up. So I try to avoid that now. But yeah, you could put ginger violet in between the toes, antifungal powder, like oh gosh, it's like right on the tip of my tongue. Let me think about it. Let me just Okay, I because it was just on the tip of my tongue, nystatin powder. I love me some nystatin powder for in between the toes. If you need a cheaper alternative, some patients do get the Viconazole powder, but just go by what your doctor recommends and prescribe. But nystatin powder, I do love nystatin powder for in between the toes, especially if there's fungus and to keep the area nice and dry. Even I sometimes use when my patients have like these full blown leg wounds. And during the summertime when it's hot and sweaty, I do use nystatin powder to keep their leg nice and dry and prevent any fungal infections from the sweatiness and the wound drainage. It's very helpful. That's my way, but every physician has their own way of helping to prevent fungus from their patients, especially during the hot, sweaty summertime. Okay. But like I said, no in between the toes. Never apply Vaseline in between the foam. Never apply thick creams in between the foam. Never apply heavy ointments in between the toes. Why? Because in between the toes are like a fold, right? It's sealed shut. There's no airflow in between it. There's going to be a high fungal risk. There is a high maceration risk. And in between your toes should always be clean, dry, and monitored. No coating all of that. I'm not going to sugarcoat it. So, what happens if you do put Vaseline on a diabetic foot ulcer? I do believe things will turn left. I have yet to see it really help a diabetic foot ulcer. So no, Vaseline does not help diabetic foot ulcers heal. Absolutely not. Vaseline is not an antibiotic. It's not a growth factor. It's not a skin substitute, and it's not a debriding agent. Okay, it does not actively repair tissue. what Vaseline does, it like we said, it is a occlusive barrier, right? So that means that there's no oxygen getting in, right? It's retaining moisture, it's retaining the bacteria, it's reducing evaporation. It does help protect exposed tissue from drying out, right? But there are appropriate wound care products for that. But moisture wound environment can support healing, but that's moisture wound balance healing concept, okay? The wound care physician will know. But the problem with diabetic foot ulcers, they're never just one problem, right? Most diabetic foot ulcers, they have multiple issues. It's a pressure issue, it's a ischemic issue, there's neuropathy, there's bacterial contamination, there's that biofilm, okay? So simply trapping moisture in does not address the problem at all. And in some situations, this petroleum jelly will create even more complications, and then you're gonna wish you never even put that on there. Number one, the biggest risk, like we said, is maceration. Too much of something is bad enough, right? I'm singing the Spice Girls, okay? We love me some Spice Girls. And maceration, too much of Vaseline is going to cause maceration. We do not want that. The skin is around, it's going to get white, boggy, and fragile. Just like I always try to tell my patients, it's like when you put your hand in water for too long and it becomes that pruny white. Yeah, because it's too much moisture and it breaks down very easily as well. Macerated tissue breaks down more easily and that will cause the wound to enlarge. That's why we always try to prevent maceration for our wounds, right? With petroleum jelly, infection can be missed. If you're coating your wound surface with petroleum jelly, the patients can mistakenly believe, oh, the wound looks shiny, must be healing. Absolutely not. It's shiny because the bacterial burden is increasing, the drainage is increasing, the infection is increasing. It looks shiny because it's nice and shiny for the infection. Okay. The jelly itself does not cause an infection. It's creating a false security and also it's trapping in the bacteria and is actually helping its biofilm. Okay. So we don't want that. It can also delay proper treatment. That's one thing I need to just go down the road of the beaten path or be a horse till the end, okay? Do not delay any care when it comes to your diabetic feet or any diabetic issue. Do not delay your proper care, okay? What I always say is whenever I notice patients try to self-medicate at home, you always still end up seeing a physician or getting admitted into the hospital. So the best thing to do if you want to avoid getting admitted to the hospital is to get early care intervention with an actual physician, right? So go to a wound care specialist, go to your diabetic foot podiatrist, go to the right people so that you can get early intervention because the earlier you go, the less treatments you need, in my opinion, okay? Because you're not at that end stage where we're going to have to admit you for IV antibiotics, have to do debridement, might have to do an amputation. No. The moment that you see anything slightly off with your foot, that does not matter. Go to your doctor immediately, okay? Because anything that's slightly a little off with your foot, it's going to exacerbate with time. And you have to also remember if you're not feeling any pain, that's the biggest barrier for you, okay? You won't know. Nobody looks at their feet every day, but as a diabetic, you have to, okay? I don't even look at my feet every day, even though I know I should, right? I'm not a diabetic, but I know I have to practice what I preach. But as a diabetic patient, you have to every day, okay? And like I said, I like the concept of the lady who said that put a mirror in front of your toilet so that you can just, while you're on the toilet, you could just lift your feet up and look while you're just sitting there on the toilet and just check, and then check in between your toes, okay? But delayed proper care, don't ever do that, okay? Many patients we see, they do use Vaseline or home remedies or herbal preparations, and they ignore the proper treatment and going to the right physician. Like there's other things that need to be done, offloading, vascular assessment, debridement, infection management. So it can make the infection worse, and then a month later you present and it might have exposed tendon, osteomyelitis, gangrene, okay? Some people do use petroleum jelly around the wound, right? Adaptic has petroleum jelly in it, right? It's a mesh, right? A sterile mesh that you could put, right? Some people like that, especially for skin substitutes, right? But clinicians sometimes, I would just let the clinician do it, okay? Let the expert do it because you're never wrong when letting an expert do it, right? In my opinion. But sometimes I use it around the surrounding skin to protect. I like zinc oxide better, okay? Protect the peri wound, certain dressings, prevent adhesive trauma, okay? There are adhesive trauma to what is it? It's like wipes to use ahead of time, okay? but it's supposed to be for around the wound, not the wound itself, but I just don't use it at all, okay? I will use Adaptic for skin substitute or Adaptic if it's, like, something that needs a moisture balance, and then, we have, like, Seroform, right? But no, I rarely, I never ever use Vaseline, okay, on diabetic patient. I just never do. There's amylactin, there's the right creams, okay? You can even use a compound pharmacy company to make the appropriate diabetic lotion for your patient, okay? But in our modern foot care perspective, if a diabetic ulcer exists, the priorities are pressure relief, vascular evaluation assessment, infection control, debridement, moisture balance, and advanced wound therapies when needed. Okay. No petroleum jelly. Okay. Like AKA Vaseline. Okay. Because you're just going to trap it in. Okay. The wound care specialist will know. Okay. And then post wound healing, I know patients will be like, oh, I was just putting Vaseline on it. And then all of a sudden it gets macerated and breaks open again. The skin after ulcer heals is very fragile, very thin, has low elasticity, and poorly pigmented initially. I always try to tell my patients, especially my patients of darker ethnicities, it's pink now, but it will come back. Okay, it will get its skin color back, but it looks beautiful right now, doesn't it? Because it's cold and it's new baby skin. Okay, it's like a baby. Okay, so we have to think about our control moisturization. Okay, the best approach is a light ceramide lotion. You can use a urea cream for hyperkeratosis. Go by what your physician says. Okay, so in the end, Vaseline is occlusive, it retains moisture and infection, okay? Do not use it on infected foot or diabetic foot. I wouldn't, okay? No more is better. A lot of people like to do that. The thickness only increases the risk, okay? It only makes the risk thicker too, okay? So in the end, Vaseline is occlusive and a sealant. It is not a treatment, okay? There are diabetic lotions that are going to help hydrate and repair. Use that on closed skin, okay? And our diabetic feet are our first priority, okay? Requires precisional treatment. So the real question, should I use Vaseline? I would just go with a no. Okay, I would just go with a no when it comes to my diabetic patients. Okay, let's just go err on the side of caution. Just don't use it. Speak to your podiatrist about what is recommended or your wound care specialist what is recommended for your skin, especially after you heal, because yay, you're done, right? So now we have to just do the maintenance, okay? Because diabetic foot care, the wrong barrier in the wrong place does not protect the foot at all. It actually traps in the problem. That's the problem, okay? So even though Vaseline is one of the most successful products created, I mean, it's good for your face, for women's face, especially to help with healing. Oh, another thing, do not use it, do not eat it, okay? They said the dude who created it ate it, do not eat it, okay? Absolutely do not, okay? Please stop it. Do not, okay? For our dry diabetic skin, I would just use like amylactin or a nice diabetic lotion. Like I said, you can even use compound companies to, I just hit my microphone, to make that patient a specialized cream because some patients have allergies too. You have to think about that too. I've had to do that for some of my diabetic patients, create a diabetic cream through a compound pharmacy and rule out their forgive me, something jump scared me, but yeah, in the end, this is Diabetic Foot File. Hope everybody's having a great weekend. I'm Dr. G, and take care of your feet because they take care of you. And yeah, sorry, I was like, ooh, I was like jump scare. Yeah.